Hello, welcome to this pre-lecture. Today I'll be talking about the classification of neuroanatomy of memory, and I'm Dr. Sarah Mitchell. I'm an assistant professor at the University of Toronto and a neurologist at Sunnybrook Health Sciences Centre. I have no relevant disclosures. I'm going to review first off the learning objectives, which will be to meet the following end-of-week objectives. So to describe the difference between declarative and non-declarative memory, describe episodic memory, which will be our focus, and its neuroanatomical underpinnings, including the hippocampus and Papez circuit, describe semantic, working, and procedural memory and their neuroanatomical underpinnings, and finally to recognize the typical clinical deficits that are resulting from dysfunction of different types of memory and the neurological disorders which can present as deficits in memory. A brief outline for this pre-module is we'll review the classification of memory. We'll talk about the difference between declarative and non-declarative memory. We'll focus on episodic memory, the hippocampal anatomy and the circuit of Papez, and then we'll review briefly semantic, working, and procedural memory. So to begin, what's the difference between declarative and non-declarative memory? Well, some people refer to declarative memory as explicit memory, and it refers to memories that can be put into words. This is to be contrasted with non-declarative memory or implicit memory, memories that cannot be put into words. And we're going to go through some examples. Non-declarative memory, the classic example is procedural memory, which we'll talk a little bit more about. And the subtypes of declarative memory that you should be aware of are episodic memory, primarily, as well as semantic memory and working memory. What is episodic memory? Episodic memory is a type of declarative or explicit memory. And the real definition is the knowledge of personal episodes or experiences, so things about your own life. For instance, remembering a short story that you heard or the events of your last birthday. There's two major types. There's the verbal type of episodic memory, and then there's visual types of episodic memory, such as where you placed your keys around the house, for instance. The underpinnings in terms of the major anatomic structures are really the medial temporal lobes, which are the seat of episodic memory in the brain. More specifically, the hippocampus, as well as the extrahippocampal structures, of which we'll review the anatomy. And then outside of the medial temporal lobes is the circuit of Papez, which we'll also review. How do you test for episodic memory? Well, to test verbally, the most classic test would be to give someone a set of words, such as a word list, have them repeat them, and then recall them after a delay, usually with a distracting maneuver in between. Sometimes it's done very quickly, within 30 seconds to a minute. Other times there's a longer delay, 3 minutes, 5 minutes, 10 minutes, and so forth. Visual episodic memory can be tested through having someone recall a figure that they may initially copy, such as this complex one you see in front of you. You have them copy the picture, and then at a delay period, you have them reproduce the picture from memory. And that would be non-verbally dependent, so purely a visual memory task. An example of a clinical deficit in episodic memory would be someone who can't remember, for instance, what they ate for breakfast that morning, or they can't remember where they went on a recent vacation, for instance. A visual episodic memory, those would be examples of verbal. Visual episodic memory deficit would be that you can't recall the location of your dinner plates in your kitchen, or maybe you're trying to navigate to your local drugstore and you can't recall which side of the street it's on, whereas you knew this previously because you've been there lots of times. Representative neurological disorders would be Alzheimer's disease as the typical one, which is a medial temporal lobe heavy predominant pathology. Herpes encephalitis is another type of infectious etiology that affects primarily the medial temporal lobes, as well as hypoxic ischemic injury can cause this type of amnesia in episodic memory due to vulnerabilities in specific areas there. Episodic memory can decline with normal aging. There are three main stages to episodic memory. There's first encoding, which is more of an attentional process. So you have to pay attention to something in order to encode it. Then there's consolidation, which is really storage of that information for later recall. Consolidation is the portion that's really heavily dependent on the hippocampus. And finally, there's the retrieval process, which is a later act of remembering, trying to pull out that information. So it has to first be encoded and then consolidated. And the retrieval process can sometimes be improved through cueing. So sometimes if a memory is consolidated properly, but the person can't recall it outright, you may be able to give them a cue, and in which case they'll be able to retrieve the information more readily. In terms of the anatomy of episodic memory, again, as I've mentioned previously, it's very much dependent on the hippocampus. To the left of this screen on the image, you'll see a coronal T1 MRI sequence with a yellow box outlining the medial temporal lobe structures within which you can make out the distinctly curved structure of the hippocampus. It's called the hippocampus because of its seahorse-like shape, which is related to the Greek word for seahorse. To the right, you can see a schemata of the hippocampus in more detail. And here you can see the whole hippocampal formation. This includes the hippocampus proper, which is the regions outlined as Ca. It is said to look like the ancient Egyptian god Amon's horn, and so therefore it's called Cornu Amonis, or Amon's horn, Ca, and there's Ca regions designated as Ca1 through Ca4. Then you can see the parahippocampal gyrus, which consists of the entorhinal cortex and the subiculum, connected by the dentate gyrus, which is the gray matter structure connecting those areas. The perforant pathway within the hippocampus is the intrahippocampal pathway that's responsible for distribution and connection of memory information. So memory enters through, or storage of information learned enters through the entorhinal cortex, which is the major input to the hippocampal structure. It then goes to the dentate gyrus, which then transmits information to Ca3, which then goes to give information via the Schaefer collaterals to Ca1. And finally, it goes to the subiculum, which is the major outpost of the hippocampus. The subiculum will feed back into the entorhinal cortex, as well as out through the fornix to other portions of the brain, including Papé's circuit, which we'll talk about now. The circuit of Papé, or PAPES as some people call it, is the declarative memory circuit of the brain. It takes information from the perforant hippocampal pathway to other areas of the brain and adds emotional valence. It's a critical portion of the limbic system. So information comes from the hippocampus and travels through the fornix into the mammillary bodies. And then from the mammillary bodies, it travels up to the anterior nucleus of the thalamus, and then out through the cingulate gyrus, and then back. So to go into that in a bit more detail, here you can see a schemata of the circuit of Papé. So you have the input through the subiculum in the hippocampus. It then travels through the fornix, the white matter tract, to the mammillary bodies where it synapses. Then it travels from the mammillary bodies through the mammillothalamic tracts to the anterior nucleus of the thalamus, which is the next area where it synapses. It then travels through the thalamocortical fibers out to the neocortex, to the cingulate gyrus, and then from there it travels back again through the corticohippocampal fibers back to the hippocampus, which is why it's referred to as a circuit, as it goes all the way back to the beginning where it started. Again, the circuit of Papé is important for emotional memories and is a portion of the limbic system within the brain. Some people refer to it as the limbic lobe, as a separate lobe within the brain. Now we'll talk about other types of memory aside from episodic memory. Semantic memory is also another type of declarative or explicit memory. It is defined as the knowledge of facts or objects, so things like knowing the first Prime Minister of Canada, knowing the color of a lion. And the major anatomic structures are really within the temporal lobes as well, but more anteriorly and inferiorly within the temporal lobes, as opposed to the medial temporal lobes where episodic memory sits. A clinical deficit in semantic memory would be not being able to remember the number of weeks in a year, for instance, or to identify the breed of your family dog, where you might have known that information previously. People with semantic memory issues tend to refer to most household items as things because they can't recall exactly what they are. And a representative neurological disorder would be the semantic variant of primary progressive aphasia. Its previous incarnation was as semantic dementia, and it's under the broader umbrella term of frontotemporal dementia. And we'll review this more in some of the in-class lectures, as well as in some of your readings. This type of memory does not tend to decline with normal aging. How do you test for it? Well, one example would just be a simple picture naming task, so having them name both frequent and non-frequent items. But as well, sometimes to get a deeper sense of semantic memory, you might have an item in the middle of this that you would have to make a semantic association. For instance, a monkey, and someone could say a banana, or an orange, and someone would say a banana goes with that item. So understanding what the item is for as well. In terms of working memory, that's the last type of declarative or explicit memory that we'll discuss today. And it's really a measure heavily dependent on attention. So it refers to the ability to temporarily keep knowledge at hand for manipulation or for specific use. Most common one would be remembering a phone number. So phonological examples, someone gives you a list of numbers, up to 7 or more. You have to recall them and then use them to dial into your phone. There's also spatial working memory, which is your ability to navigate yourself in space following a route that's planned and remember where you are and where you're going and constantly update that information and attend to it. In terms of its anatomic underpinnings, it's more of a distributed process in the brain as opposed to a specific localization, but we do know that it involves the prefrontal cortex, so the area at the very front of the frontal lobe sitting above the eyes, the subcortical structures, as well as the parietal association cortices, which are very important for spatial working memory. An example of how to test to it would be doing something called the digit span test, which again is similar to giving someone a phone number to recall. You give them a sequence of numbers and have them repeat them back to you. You do it forwards, and then you also do it backwards. So they have to manipulate that information, keep it online within the brain, and then use it to be able to say the numbers in a backwards order. So 1, 2, 2, 1, and so on and so forth. A clinical deficit, as an example of a working memory clinical deficit, would be not being able to recall a phone number immediately after hearing it. Or, this is a classic one, is that someone can't recall why they're traveling from one room to the next. For instance, someone might give them a request to pick something up from one room and bring it to another room, and they arrive at the room and they can't remember the reason that they're there. So they can't keep the information, again, online in order to be able to follow it. In terms of representative neurological disorders, vascular dementia, due to its predominant pathology within the subcortical white matter due to lots of microangiopathic disease, can be a representative example. Similarly, pseudodementia from a major depressive disorder can look like this. Traumatic brain injury or post-concussive syndrome can also have deficits in working memory. And it may decline somewhat as well with normal aging. The last type is our iconic example of non-declarative or explicit memory, which is memory that cannot be put into words, and that's procedural memory. So it's the ability to learn cognitive and behavioral skills and algorithms that are automated or unconscious. And a classic example of that is riding a bike, or playing the piano, or playing an instrument, something that you've learned to do that you retain the memory for, but is difficult to put into words. The major anatomic structures of the brain that underpin these activities are the motor areas of the brain, so the basal ganglia, the cerebellum, the supplementary motor areas. And again, this is more of a distributed process as opposed to a one-to-one correlation. A clinical deficit example of procedural memory would be someone who forgets how to ride a bike, or someone who's previously knew how to play the violin but could not recall how to hold the bow. Procedural memory is not commonly tested at the bedside, so it's more something that you would ask about on history. And some representative neurological disorders would be Parkinson's disease or Huntington's disease, in which there's motor abnormalities. And it does not tend to decline with normal aging. Just a slide here for review to summarize the anatomy of semantic and procedural memory as well as working memory. You can see in blue, the semantic memory is primarily located within the inferolateral as well as the anterior temporal lobes. Anterior not as much pictured here. The green represents procedural memory, which is distributed through the supplementary motor areas, the basal ganglia and the cerebellum. And finally, working memory, which we discussed, is a more distributed process here represented by the involvement of the prefrontal cortex, but also remember subcortical structures, parietal association areas, etc. So now we'll review the learning objectives again. By now, you should be able to describe the difference between declarative and non-declarative memory, describe episodic memory and its neuroanatomic underpinnings, including the hippocampus and the Papez circuit, describe semantic, working, and procedural memory and their neuroanatomical underpinnings, and finally recognize the typical clinical deficits resulting from dysfunction of different types of memory and the neurological disorders which can present as deficits in memory. And those are my acknowledgements. Thank you for your attention.